Good afternoon, everyone. And just before we start, we'd just like to remind everyone on this platform to reach out to someone, share the stream, share the live stream, invite others to join this forum. This is a very, very important forum. So we're asking everyone on at the moment, if you have not shared the live yet, please do so. We're also asking persons to invite others, invite your friends, invite family members who's not in your home circle with you, especially if you're based in Grenada. As you know, this is lockdown weekend, and the persons who are not in your household at the moment that you'd like to hear the information that we're about to share, please invite them to join the link, send them the Zoom link, send them the Facebook page so they can be part of this very, very important discussion. I have shared my link, and I'm hoping that everyone has done so also. Just giving everyone a moment to share their link with persons who need to have this information. In fact, it's one of the forums that everyone needs to share. Share it on Facebook, share it on your social media platform, Instagram, however you connect with your friends and family members. Please share the link. All right. Good afternoon, everyone, and welcome to another TGM Forum. COVID-19, Perspectives from the Frontline. And at this point, I'd like to share with you our dashboard here in Grenada. COVID-19, as of yesterday, 351 new cases, 2,444 active cases locally, 74 persons hospitalized, and that is as of yesterday, 3,841 total cases to date since the first case, 305 persons in quarantine or isolation, a total of 2,444 people have been quarantined so far or isolated, 1,347 recoveries. Vaccination numbers, 3,100, that is 31,721 first dose, and 21,348 fully vaccinated persons so far. Again, good afternoon and welcome. We're talking today about perspectives from the frontline, and we have with us our esteemed presenter, Dr. Harripaul, to share the science. Dr. Harripaul will tell us of his experiences on the front line as we seek to get a handle on our COVID-19 situation here in Grenada. Good afternoon to all, wherever you are at the moment. Welcome, Dr. Harripaul.
Good afternoon, and thank you for having me on your stream. I will attempt to give a brief account of my experience in the front line, as I work in the front line since the start of the pandemic, which we all know started in 2019, and it didn't really hit us in the UK until 2020. People were not taking it too seriously. Some people were passing it off as flu-like symptoms, and I think in the UK it caught us a bit by surprise. When it arrived on the shores, the effect wasn't too devastating at the onset. Um, I arrived back in the UK from Trinidad in February, and there was whisperings of this COVID-19 outbreak. And it was only until March, really, that we started to see cases on the floor. The first week of March, we saw in the UK between 1 to 3 deaths. And again, people were not taking that too seriously. 1 to 3 deaths in a population of 66 million is, nobody was going to panic too much about that. But as we know from our experience with COVID, those numbers escalated quite dramatically. And by the end of March, so in the beginning of March, we had 1 to 3 deaths. By the end of March, the numbers skyrocketed to 1,000 deaths per day, which was the equivalent of like wiping out a small village in the UK every day. And it's then that people realized that this was something to be taken seriously. In my own hospital, we started seeing cases of COVID coming in. I remember very well being on the floor on the first day that COVID arrived in our hospital, and there was, generalized panic on the floor. People didn't really know what to do. The whole half the ground floor was cordoned off because of one patient with COVID. And eventually more and more patients started to come in. Processes had to be developed very quickly to deal with the incoming cases. The areas of the hospital wards had to be cordoned off and allocated to these patients to deal with them. And we didn't have too much information about COVID at the time. This was at the onset of the pandemic. Cases were rising rapidly. We didn't even know how the transmission occurred. There were various theories, some saying that it was transmitted by fomites on surfaces. And it was only later on we learned that it was also by aerosol. So the early days were very traumatic. We had no treatment for this condition. We knew very little about the transmission. People were dying despite everything that we could do. ITUs were being overwhelmed, and there wasn't any room. And eventually protocols had to be developed to decide who would be admitted to the ITU setting. The initial course of the pandemic with no treatment meant that if you had it, you had an oxygen requirement, it was unlikely that you would survive the infection. The course of the illness was like nothing that we have ever seen before. It was a dramatic downhill course. People would be talking to you and smiling with you on admission and be very hypoxic with low oxygen concentrations. And we eventually grew to learn that despite them being so well and chatting on admission, within 24 hours, these people would no longer be with us. So as the pandemic grew, of course, no administration could expect to hold out with deaths of 1,000 a day, and the country went into full lockdown. And eventually, with the lockdown, which was pretty effective, the numbers started to fall because you starved the virus. Obviously, it is not going to multiply. So by summer, we were in a much better place. The numbers had fallen, the deaths had fallen, and there was a little bit of complacency. People thought that this was the end of the pandemic, and things started to get a bit relaxed until the end of summer when the numbers started to rise again. So by September, we started to have cases going up. And this continued into winter. Pressures once more started to build in the hospitals. So we had increasing numbers of COVID coming in. Of interest, what we noticed in the first wave was the disproportionate amount of mortality and morbidity in the Black and Asian and ethnic minority population. So much so that some studies were done in the BMJ, the British Medical Journal, and the Lancet, which to find out why this was so. And indeed, when we looked at some of the fatalities in the medical profession, because we lost colleagues as well in the medical profession, they seem to be coming from the Black, Asian, and ethnic minority populations. There were various reasons for this. One of it is that most of us are in the front line, and we were exposed in those days to high titers of the virus. And with no defenses, people got COVID. I lost two colleagues in the first wave from COVID because there was nothing, we had no treatment for this. We had no vaccination. So by the second wave, which peaked in the second wave, it peaked in January of 2021. During the Christmas break, there was Christmas wasn't cancelled. Things went on as usual, and numbers continued to rise until in January we hit 1,500 deaths per day, which is a tremendous number. Luckily, however, there was the arrival of the vaccination program in December, which started in December with the Pfizer-BioNTech vaccine. The first dose was administered on the 8th of December. 90-year-old Welsh woman received the first vaccine. And from then on, the NHS, the National Health Service, embarked on the largest mass vaccination program in its history. By February, the end of January into February, 6 million people were vaccinated. And that was in the 80+ group, which is a tremendous number of people to be vaccinated in that group. No one knew at the start of the vaccination program how the vaccines would be received, whether people would not take it or be hesitant to take it. But surprisingly, the British public, embraced the program, and it really took off. With one exception, with a couple of exceptions. Again, there was hesitancy in the Black and Asian population. So I can give you some figures of what we experienced. And so in the 70 to 79-year-old age group, we had a vaccine take-up of 85% in that group. But within that group, people of Caribbean ethnicity, 61% did not get vaccinated. Of the African group, we had figures of, 50%. Bangladeshi, 80%. So again, we had a little bit of a problem with the Caribbean population not taking up their vaccines, whereas the other groups were taking it up quickly. This again, various reasons for this were postulated. The UK is a very diverse population with many different ethnic groups, which, unlike the Caribbean, don't necessarily tend to mix in the general population, and they tend to be within their own communities. So penetrating that group was a problem. And there were various strategies used to try and get information into that group to get these people vaccinated. So the vaccination program really took off in 2021, and on the floor, we started to notice it almost immediately. By March, I would say by March or April, the cases started to fall significantly. The hospital admissions fell off significantly. The people that we were seeing in the hospital who came in with COVID were not as ill, were not as sick. They didn't require ITU admissions as before. So that seemed to be a direct effect of having the vaccine. Of complications, I have seen one in the last 18 months from AstraZeneca vaccine, which involved a central venous clot, which was not fatal and treatable. But apart from that, people seem to have tolerated it very well, with very little side effects. So now we are seeing where we are now. In the last 6 months, there has been no fatalities in the 50 to 59-year age group and below from COVID in vaccinated individuals. So let me repeat that. No fatalities, zero fatalities in between 50 to 59 and below. The fatalities that we see from people who are vaccinated with one of the vaccines, we have seen 256 in the last first half of the year. These are people in the above 60, between 60 to 100. These are people with significant comorbidities. They probably would have died from any insult, any infection, COVID included. So our numbers are falling significantly. We have no patients with COVID currently in the hospital. Last week we had a couple. Now we have this the following week after that we had absolutely none. The people who come in who are vaccinated, who have caught COVID, because you still can catch COVID despite being vaccinated, tend to be not as ill, tend to not require ITU. The very ill people that we are currently seeing are people who have not been vaccinated. These are the people who are ending up in ITU, unfortunately. Luckily, we have some treatments now that we didn't have in the first wave and at the start of the pandemic, which improves your ability to survive this infection if you get it early enough. We have steroids, we have antivirals that we use now, which tend to be more effective in preventing death. And in terms of the future, well, happily, the gap between people who were initially hesitant to have this vaccine has now narrowed significantly, so that there are more people from the Caribbean and other ethnic groups who are now being vaccinated. So somehow they've managed to get the information out there. From the Lancet journal, they said that they were targeting community leaders, religious leaders, to try and get the information to the people. Because remember, these are groups that don't necessarily mix with the general population. So getting information to them was quite important, especially to the people who had influence over these particular groups. So the gap has narrowed. There's still a gap, but it has narrowed. And in terms of going forward, this is a virus that is not going to go away. It is not going to disappear. We're not going to stop seeing it. It has become endemic in the world. And the only way to control it is to vaccinate and get the message across to vaccinate. And to get the correct information across and to the relevant people who are hesitant to vaccinate. So in the UK, we are now looking at booster vaccinations. So third shot from the autumn, vaccinating the 50 plus age group in an attempt to boost the immunity and prevent COVID from really spreading, because it is going to spread and it is not going to just stop and go away. That really is the message to get across, that COVID really is not going to suddenly disappear from the world. And if you give it opportunity to be present and to multiply, it is going to mutate. That is the nature of a coronavirus. It's going to mutate. So on the floor at the moment, we are pretty comfortable. We feel a bit safer in terms of our practice in dealing with patients with COVID, which we didn't feel that way at the start. When we didn't have any treatment, we didn't have any vaccination, there was always the threat that you were going to get this virus and it could make you very unwell. I will give you a little story about some of the difficulties that we face in terms of getting the message across. Now, I was seeing a patient in the emergency department. One of my junior doctors, for the first time in many years, was a doctor from Grenada, believe it or not. So she was doing her SHO posting in medicine. So she clocked in a patient, she saw a patient, and presented the patient to me, a patient who came in with shortness of breath, middle-aged man. So she presented the patient and, told me all the details of the patient and asked to see the x-ray of the patient. And so she put the x-ray on the computer screen. I said, oh, this looks like COVID. Have we done the COVID test on this patient? That's a typical COVID x-ray. And she was taken aback a bit. So I said, good thing we're protected and we've been vaccinated. I said, what vaccine did you have? So she said, I haven't been vaccinated, which, and my turn to be taken aback because, yeah, why is it you're not vaccinated? You are in the front line. You're dealing with potentially patients with COVID coming in. So she said she has a friend in Grenada who took the vaccine and got palpitations, and the friend didn't want to take the second vaccine. So as a result of that, she didn't want to take the vaccine. So I said, that's, not really relevant to you. What happened to your friend? And we don't know that is a result of vaccination. And then she asked, what about, things like fertility? People have been saying, vaccine causes infertility. So we had to go through a lecture of what the vaccines were and, how it couldn't possibly cause infertility. But there's an example of, here's a highly educated young woman who should have all the information, who should know, what the vaccines are, what they do, who is listening to what the friend says, who is not medical at all. And social media is a big issue in how information gets carried across. So in conclusion, I would say that from the start of this pandemic to where we are now, we are in a much better place. In the UK, we have a good level of immunity. More than 4 out of 5 people are vaccinated. More than 9 out of 10 people have antibodies to COVID-19, and with the third shot, with the booster, I expect that we will continue to be in this position that we are. With winter coming, we expect our numbers to go up. People are going to continue to die from this virus. There's no way that you can stop that. But what we can do is offer the best protection that we possibly can, which is to take, whatever vaccine is available at the time that offers the protection. And I think that basically is my message, that from the view on the ground, on the front line, is that we have become more comfortable in our practice and in dealing with COVID without the fear of significant harm coming to us. So I'd like to thank you very much for having me, and I hope the information has been useful and informative from the perspective here in the UK, where we see a lot more cases than the smaller countries. So thank you very much.
Thank you very much, Dr. Harripaul. I have questions, and I'm sure a lot of the folks listening has a lot of questions also. So I'm going to be very selfish and start first. What I'm concerned about is treatment protocols. Someone come, or not just treatment protocols, but protocols in, for example, someone comes into the emergency room and you've determined that it's COVID. What are the next steps?
Okay.
What happens next?
All right. So there are two variables here. So one is that you have what we call the worried well. So people have caught COVID and they get worried. They're worried that something dreadful is going to happen. So they come into the emergency room. They have very little symptoms, and the symptom that we worry about is hypoxia, low oxygen concentration in the blood. If they are not hypoxic, we tend to send them home with advice, what to do, what to watch, what to look out for, come back if there are any concerns. If they are hypoxic and requiring oxygen, we admit them and we watch them for a period of 24 to 48 hours for deteriorating oxygen levels in the blood. If that occurs, then we start them on a treatment protocol. The treatment protocol is usually a combination of steroids or antivirals or both, and it depends on how quickly they are deteriorating. If their oxygen demand starts to go up quite significantly, they are admitted to the intensive care unit, where they are monitored even more closely. By that time, they're usually on a combination of drugs, which tend to stabilize them and prevent them from being intubated. If you have to be intubated, it means that you cannot maintain your oxygen levels with standard oxygen delivery equipment. So you must be intubated and ventilated to allow your lungs to deliver the amount of oxygen to your body. In the first phase of the first wave of the infections, none of this worked because we had no treatment at all. So despite being intubated, people died. Now that we have these treatments, it is still touch and go if you have to be intubated. It depends on your comorbidities. The more comorbidities you have, the less likely you're going to survive infection. If you have, minimum things wrong with you, the chances are good that you will pull out of it. So it really varies depending on how you present to the emergency department as to what your pathway is going to be.
Unmute, Janice. Unmute.
I think you're muted, Janice.
Thank you. Sorry. All right. We're asking everyone with questions to just raise your hands in the chat and I will acknowledge your questions. I will acknowledge you and you'll be able to ask your question. Austin, I noticed you had a question for Dr. Harripaul.
Thank you very much, Janice. Good afternoon or good evening, Dr. Harripaul. This is Austin in Trinidad.
All right.
You did not mention, I think, something that has been of concern. In fact, it's given some of us sleepless nights, and that is the role that the variants may have.
Yes.
In the spread of infection or the, shall I say, the level of danger associated with infection.
Yes. Well, we quite so. So we have several variants that are around at the moment, and you are going to get more variants coming as well. So the particular variant that is of worry at the moment is the one called the mu variant. And the mu variant is not present in large numbers at the moment. But the worry is that it's going to be vaccine resistant. We don't know enough about it yet because it's not around in large numbers. We only had 5 or 6 cases in the UK. And variants are always going to be a cause of concern. The companies, the the manufacturers say that with our present technology, they can adapt to variants very quickly. It's a matter of knowing which spike protein has been modified and to modify the vaccine in response to that. So it's always going to be a battle to try and contain variants. Now, variants are going to be present as long as the virus is able to multiply. So if you have large numbers of virus, load multiplying, then you're going to have variants emerging. There's nothing we can do about that, unfortunately. It's the nature of viruses. That's what they do. The only purpose for existence is to multiply and survive. And by starting a vaccination program, we have put an evolutionary pressure on the virus to mutate. So by making it more difficult for it to multiply, it's going to find a way to multiply. And the way it does that is by mutating. So we are always going to have to try and be on top of this mutation.
Thank you very much, Dr. Harripaul. I'm noticing Dr. Patrick Entwine has a question.
Yes, thank you so much, Janice. And I just want to join with us and just saying how very informative this has been. A couple of things. The Delta variant, what have you been noticing in relation to the program of vaccination you've instituted for the Delta variant? And when did you actually start focusing on that in your vaccination? Let's call it policy or strategy. In short, we're noticing in the Caribbean, not just Grenada, the presence of the Delta. We're hearing a lot about the third dose in the UK is the case. Is it that your third dose is actually a response to the Delta plus others? How have you sequenced that, and what have you noticed from the time you've actually begun observing the emergence of the Delta variant, and what was your coordinated strategy to respond to it if it wasn't just vaccination?
Right. So the Delta variant has been the source of the major source of problems here. I think if it wasn't for the Delta variant, we would have been way on top of this virus. The Delta variant is the one that multiplies the quickest. It has greater transmissibility, and the vaccines they're not as efficacious in the Delta variant as they were in the primary coronavirus. So I think that's why we're still seeing the numbers of infections that we're seeing. It's because Delta is the one that is causing the volume that we currently have. What is promising is that even though we're seeing the volume because of this Delta variant, we're not seeing the equivalent number of deaths occurring. So I think although the vaccine doesn't prevent as much Delta transmission as with the primary coronavirus, it does prevent the mortality and morbidity. The aim of the third dose is to combine, is to have a combination of different vaccines. So the people who had the first dose, let's say they had AstraZeneca as their first two doses, the third dose is going to be Pfizer or Moderna. And the rationale behind that is that by combining these two different vaccines that work on two different mechanisms, it will boost the immune system and provide greater immunity against these variants that are popping up. And I think that's the focus. The focus is to boost immunity in the community. We already have herd immunity. It's now to try and boost the immunity that we do have, because it's not going to last forever. The immunity, it's going to wane, and if it wanes at the time when the virus will be the strongest, i.e., winter, then we're going to be in some trouble. So that's the rationale behind it.
All right,
So-
thank you.
Yeah.
Oh, sorry. I'm sorry.
No, carry on.
No, I thought you had come to the end of your
Yes.
answer. All right. So I have a couple questions coming in from social media. Again, I'm sorry. I didn't mean to break your train of thought. I have another question coming in from social media. Someone is asking, well, a couple of them actually. Adriano is asking, can a recovered COVID patient be reinfected? Ezra is asking, how soon can a mother who just delivered a baby take the vaccine? Dahlia is asking, good afternoon, everyone. She'd like to clear the air about the spread of the virus, whether it's the vaccinated or the unvaccinated that's causing the spread, vaccinated or unvaccinated people that's causing the spread. And Kenra is asking, is there any chance of viral shedding from the COVID-19 vaccine?
Okay, well, let's see if we can tackle that one at a time.
Yes,
So,
sure.
So reinfection, can somebody who's had COVID be reinfected? The answer to that is yes, you can be reinfected. And very early on in the pandemic, we saw people who had gotten COVID and recovered from COVID, and 3 months later they got COVID again. So yes, you can be reinfected. And even if you're vaccinated, you can be infected. So it's not the vaccines, as we've said before, it's not 100% effective at preventing you from getting infected. In terms of pregnancy, I'll have to pass on that one because I don't have any info on how soon after pregnancy you can be vaccinated. So apologies for that, but I don't have the figures for that one. There was a question about, was it vaccinated versus unvaccinated? What was the question about?
There is a concern on the ground here that
Yes.
the unvaccinated people,
Yes.
for example, one of the things that's happening in Grenada is a person coming in vaccinated into the island is in quarantine for 48 hours, as opposed to a person not vaccinated that's in quarantine for at least 7 days. So I think the person's concern is whether the unvaccinated people who probably may have come in contact with the virus again is responsible for spread.
Right. So the unvaccinated people who come into the island can come into the island with no symptoms at all and only present with symptoms a week later. So the purpose of quarantining for a longer period of time is that it takes that long to manifest some symptoms of COVID. The vaccinated people, they can still harbor the infection. So even though you're vaccinated, you may not initially present with symptoms or indeed with a positive PCR test. But usually within 48 hours, which is the rationale behind that sort of time frame, if you are retested within that period of time and you have COVID, despite being vaccinated, it will come positive. So that's sort of the rationale behind those sort of time frames that they use to quarantine people. And there was another question about the viral shedding. What?
You're muted, Janice.
Yes, I think you muted Janice.
I'm
Janice?
sorry. I was going back to that question. I was toggling between screens to get to that question because that question came in on social media. So
Right.
Kenroy is asking, is there any chance of viral shedding from the COVID-19 vaccine?
Viral shedding, meaning as if you can spread it if you've been vaccinated. I imagine that's what they mean by viral shedding. So the answer to that again is if you're vaccinated and you have the COVID, you caught it despite being vaccinated, you can still shed the virus to someone else. So the answer to that is yes. If you're vaccinated, the chances of catching it is greatly reduced, of course. But if you do catch it, you can pass it on. You can pass it on. That's why if you come into the country vaccinated with a positive PCR, they will quarantine you because you can pass it on.
Thank you very much, Dr. Harripaul. Another question coming in from Ken. Ken, please unmute your mic.
Sure, good afternoon, and thank you for your presentation. The question I have, since we're in a pandemic and this is not a simple case of just individuals probably just having an accident and it doesn't affect the rest of the world, is it possible to have a global or national COVID pandemic virus plan? And if so, what would be your recommendation?
A global plan for coronavirus. Oh,
as well as viruses as a whole, any pandemic that we're going to face in the years to come.
Well, they say this pandemic was long overdue. And it's what we can learn from this pandemic that is going to be useful in preventing future ones and developing sort of protocols to deal with them. COVID has taught us many things. It has revealed a lot about human nature. It has revealed a lot about our governmental structure, how we process things, how we deal with things, and we haven't dealt with coronavirus very well. And even in the larger countries like the UK, for instance, we handled this pandemic very badly. So it's difficult to formulate a global plan for something like this when countries are still struggling to deal with it. In the US, you still have large sections of the population who are not vaccinated. So to develop a global plan, you would have to look at a country that has been very successful in dealing with this pandemic, how they've done it, and how you can translate that to the rest of the world. And so far, we apart from the East, the countries in the East who have experience with these types of viruses, the rest of us haven't done very well with coronavirus at all. The UK has found itself on an even footing because of the vaccination program. The vaccination program was the biggest success that the UK had in dealing with this pandemic. If it was not for the vaccination program, we would have fallen a long time ago. We would have had 2,000, 3,000 cases a day easily. And it's only because of the rollout and the uptake of our vaccines that have put us in this position. So if you want to translate that into a global plan, it would have to be a vaccination program, like we did for polio and diphtheria and malaria and tuberculosis and all these things that we've tackled before. We tackled it through education and vaccination. And without that, we are not going to deal with these pandemics in the future very well. We're still learning lessons from this present pandemic. We know this is far from over. So I don't know if that completely answers your question, but it's a difficult question. It's a difficult question to answer. On coronavirus is, as I said, people say this has been long overdue, and we are going to face more in the future. These are wild viruses that are coming into contact with us now, and I don't know if that's helpful, but I think, as I say, a difficult one to completely answer.
Appreciate it, understand. In light of, one of the concerns that I think the medical personnel have today is the long-term effect of, what are the unknowns? Like in the United States, for example, 1/3 of the infected patients with COVID has neurological problems.
Yes.
And of course, the statistics for the other areas like lungs and other problematic areas. So therefore, it seemed to be it would be something that we will have to deal with for many years to come.
Absolutely correct. There are short-term and long-term effects of COVID. The younger people tend to get what we call the long COVID syndrome, which is very difficult and can manifest itself in many different ways. Particularly the cardiovascular and respiratory systems seem to be particularly affected by COVID. And although this is not very common, we still see a clear amount of long COVID syndrome. So yes, it's quite a concern. This virus, it's not to be taken lightly at all. And sometimes even if you survive this thing, its long-term effects can wreck your life.
Thank you very much, Dr. Harripaul. Another question coming in from social media. Can someone contract or have more than one variant of the virus? So can someone contract the Delta and get another variant of the virus?
Yes, the answer to that is yes. So the thing about the variants is that they manage to evade your immune system. So you develop antibodies to a particular virus. And if the purpose of that virus changing or becoming a variant is so that it can evade your immune system. So if you come in contact with a variant, you will get it. It's like the body seeing something new again. So the purpose of variants and the purpose of evolving is so that it evades your immune system and is able to reinfect you. And that, as I said, that's what coronaviruses do. They if you give them the opportunity to multiply, eventually you're going to get mutation.
I have another question. I've heard that one should not get vaccinated if they've had the virus or should wait 90 days after the infection to get vaccinated. What if someone receives the shot while infected? And if they've only received one shot so far, would the second shot be delayed because they were infected?
So yes, you shouldn't get vaccinated at least 90 days after the infection. If people have mistakenly gotten the not knowing that they had COVID, they've mistakenly gotten themselves vaccinated against COVID. We have seen maybe 3 or 4 cases of people not knowing they had COVID and they got themselves vaccinated, but nothing untoward happened. Nothing untoward happened to them. They survived with no ill effects from the vaccine, and they were fine. They were fine. I think if you had COVID and you got vaccinated with the vaccine, they tend to delay it by about 4 weeks for you having the second dose. So if you were supposed to have it like 3 weeks after or 4 weeks after, it will be delayed by a further month.
Okay. Basil, I notice you have a question followed by Devon.
Yes, good afternoon. Thank you, Doc, for your great presentation. My question is that we are seeing a rise in vaccination. We're seeing people following protocols. Also, the number is going up. The number of cases are going up. There's still public transportation has been still being filled. And so my question is this: how do we actually stop or reduce the spread significantly? I mean, other than getting vaccinated, I mean, it shows that it works, but it also shows that people can spread it while being vaccinated. So what would be some advice from you, how, other than the 6 feet and the hand sanitizing, like what can we do to actually stop this spread right now? Because this is our first wave.
Right. So what you are having is the first wave in a largely unvaccinated population. So your population has not achieved anything close to herd immunity yet. So even though your vaccination program has started, the immune levels in your population are nowhere high enough to prevent a rise in cases. What also seems to happen is that once the vaccination program starts, a sense of complacency sets in, and people do not tend to follow protocols because they know they've been vaccinated or that vaccination is ongoing. So until your population achieves herd immunity, you have to follow whatever protocols have been set out in your country. And if this includes mask wearing, social distancing, not gathering, etc., then this is what has to be followed until you have achieved herd immunity, because before that, the virus has all the opportunity to spread and infect the population. Now, the vaccinated people, although they can get COVID, the risk of acquiring this virus is greatly diminished. So the chances of them getting it and passing it on is greatly reduced. So that basically is the aim. The aim is to get your society immune. And once they have achieved herd immunity, then you start, like in the UK, you start relaxing your protocols. So the UK is now fully open because we have achieved herd immunity. There are no more restrictions on anything. There's no mask wearing. There's people, the government said, we've done our bit. We provided you the vaccines. The people said, we've done our bit. We've taken the vaccines. So the government has said, well, now the responsibility is yours. You decide what is safe to do. You decide when you want to wear a mask, where you want to wear a mask, or if you don't want to wear a mask. They have put, personal responsibility onto the population because we have now achieved herd immunity. So it's up to the individual to exercise their own precautions as they see fit. And until you get to that point, you have to follow protocol.
Thank you for that answer. Another question from social media. If someone had COVID, are they naturally immune? Why be vaccinated still?
So if you have COVID, you acquire a certain degree of immunity. And if we refer back to the previous question, where can you catch COVID again from a variant, you can catch COVID from a variant. It is now thought that if you have a COVID infection, you have immune antibodies, but they do not last as long as if you have a vaccine on board. So the immunity from the COVID infection is about 3 to 4 months, and then the antibodies start to wane, and then you are no longer protected. You can reacquire the same infection again, not necessarily a variant.
A question from Devon.
Yes, good afternoon. Sorry I missed the bulk of the presentation. I came in late. But there are a few things that concern me. I see so many people who are fully vaccinated becoming ill with COVID. Not just catching COVID, becoming ill with COVID in Grenada, and reports that several people who are vaccinated have died. In fact, I know a few people who are supposed to have been fully vaccinated and died. I've encountered a number of people also who are fully vaccinated because there are a few of us who assist people who have come down with COVID. And we see people who are vaccinated struggling as much as the unvaccinated to overcome this thing. So, like I said, I missed most of the presentation, but what my concern is that what we are seeing is that people who are vaccinated struggle as much as people who are unvaccinated from our interaction with a few dozen people. What we have found, though, is that when we use natural methods to assist people, that people have done exceptionally well. And not one of them has had to go close to a hospital. So in viewing all of this, our thought, together with thoughts that we have heard expressed, is that one very important thing for us to do to beat this thing is for us to work at changing lifestyles where necessary so that we could develop robust immune systems. And I want to hear what your comment on this is, also considering that we do not now know what the long-term effects of this new vaccine is going to have on humankind. Thanks.
Okay, thank you for your question. Right. Now, yes, as we said during the presentation, being fully vaccinated does not prevent you from dying. So there are deaths from people who have been vaccinated and have caught COVID. These are usually people who have significant comorbidities. They tend to be the older people. And it all depends on your physical makeup. As I mentioned before, since the start of our vaccination program, people in the age group 50 to 59 and below, there has not been a single death from COVID in this country. So no one below 59 has died from COVID infection who has been vaccinated. Above the age of 60, there have been deaths from COVID. And these have been people who have significant comorbidities. So it doesn't, and they would have died had they caught any other infection other than COVID, because they are frail people who have significant health issues. So the COVID vaccines are not a cure for death. So you will, if you have something that can cause you to die, you will die. And COVID vaccine is not going to prevent that. So yes, people who are fully vaccinated can die. People who are fully vaccinated, depending on their level of fitness, can also become unwell. So we have seen people who are fully vaccinated who have become unwell and, as you say, struggle. These people, if they were not vaccinated, probably would not have survived the infection at all. And it does afford them some protection, at least against dying. But if they have other comorbidities, they can certainly struggle. And in terms of changing your lifestyle and getting healthier, there is no doubt that the fitter you are, and if you are in good health, that you have a better chance of surviving the infection. There is no way to know how or which individual is going to, get very ill and who is not going to get very ill. You may be fit and you may still get very ill with COVID. There does not seem to be a rhyme or reason to it. And there's no way you can predict by if I get fit and if I get well and if I get healthy and I get COVID, I will be okay. There is no guarantee of that either. Just as the vaccine doesn't guarantee you life, getting healthy doesn't guarantee that if you get COVID, you will be okay. There is no way to tell. We've seen very healthy people who have succumbed to COVID and gotten very unwell with it. In terms of long-term effects of this vaccine, the vaccine is very short-lived. The fact that we have to store this thing, some of them at minus 80 degrees Celsius and minus 10 degrees Celsius, tells you how short-lived and how quickly it denatures outside its medium. So it's in your body for a very short period of time. These are the Pfizer and Moderna vaccines. AstraZeneca is manufactured in the same manner as all the vaccines that you have had in your childhood. And these are, as we said, very short-lived vaccines. And particularly AstraZeneca has been manufactured using processes that we know very well for a long period of time. So the chances of these things having long-term effects when they last such a short period of time in your body, and the fact that we now have to use, consider booster vaccination, tells you how short these things stay in your system, and the effects that they have in your system are so short-lived that we have to be considering things like booster vaccines to boost your immunity, because it just does not stay in your system very long or have long-term effects on the rest of your body. It has effects on your immune system, which is what vaccines do. This is the purpose of being vaccinated since childhood, is to boost your immune system and prevent you from acquiring infection. That's the purpose of vaccines.
Thank you very much, Doc. I have a question from Ezra, but in the meantime, guys, we're getting ready to wrap. I noticed another question from Dr. Entwine, so we'll do Ezra's question. So we're asking for the final 3 questions. We'll take 3 more after this, and then we wrap up this session. Ezra is asking, is there any particular underlying condition that someone may have that you would advise them against vaccination?
I have to think about that one. Off the top of my head, I can't think of anything. There are some hematological conditions that you might not want to be vaccinated against. Things like myeloproliferative disorders might be a contraindication to vaccination. But most medical conditions should be okay for vaccination. It doesn't really affect, it's not really contraindicated in heart or lung or liver disease or any of those.
All right. Dr. Entwine, another question from you?
Janice, let the other 2 colleagues go, and then perhaps I'll come up with the other colleagues who haven't spoken. I'll come up with the 3rd one. I'm ready, but I just want the other colleagues to go first since I went.
Okay. Okay. Who's next in line? Is there another question from Austin? I think.
Yes, there is. Doc, this has to do with the question of herd immunity. Do you believe, I know it's government policy and it's what is believed in the British government, but are you satisfied that the conditions have been met? Professionally, are you satisfied that the conditions have been met for the relaxing of restrictions that we are seeing today?
Right. Okay. So from a professional point of view, from what we're seeing on the floor, it certainly seems as if the volume that we were seeing has certainly diminished significantly. So in terms of serious infections, in terms of number of infections, in terms of mortality, drastically reduced. So in terms of relaxing the restrictions, at some point you have to decide, how long are you going to continue with these restrictions? At some point you have to balance, and I think that's probably what the government did. You have to balance between people's freedoms, people's the country's economy, getting people back to work, getting some normalcy back to life. Whether the restrictions have been lifted too early, we will not be able to tell for the next 2 or 3 months. So as we approach winter and we start to see the effects of opening up the country once more. So the country, as I said, is fully open, and it's fully open on the brink of a change in season where viruses tend to proliferate. The government has not ruled out another lockdown if things get out of control. So if things go out of control, restrictions will return. And the only way to slow this virus down is to, as we said, prevent it from multiplying. And if it's multiplying too much, and the health system is what drives these lockdowns, if the health system starts to get overwhelmed, it will force us into another lockdown. At the moment, the health system is not overwhelmed, and that is giving everybody the confidence to carry on with these relaxation of all the rules. But as we said before, this is far from over, and we have to see what happens, really. But at some point, you have to make a decision that you're going to open up, and if the vast majority of your population has been immunized, you have to say, why not now? I hope that sort of answers.
Thank you very much.
Dr. Entwine?
Yeah, thank you so much. Just 2 very brief comments and then 1 question. First of all, I think Ken asked a very interesting question about the sort of global strategy and action plan. But at the WHO level, where I think we've dropped the ball, certainly as a global response to this very early, it will still come down to national action. It still will come down to what is your governance structure, your constitution, and ultimately the uptake from your people and the responsiveness of your healthcare system to the disease, so that great and sort of a pandemic strategy has been sort of discussed across the table, because we have missed an opportunity here to really respond, cohesively. And I think certainly we've learned some lessons from that. But even with that responsiveness, in the best of times, it will still come down to how does China respond, and ultimately for us, how does Grenada respond when given vaccines and given the sort of healthcare system that we have. So I just wanted to make that point quickly. The second point is that I respond to lots of colleagues who speak about noticing how people struggle between those who are vaccinated and unvaccinated. One simple reminder that the Caribbean is the region in the world where we are most prone to dying from non-communicable diseases. Now that has to sink in. It means, for instance, that, whether it is hypertension, whether it is diabetes, cancer, and yes, whether it is chronic respiratory diseases, we are the region in the world, statistically, and we've known that for a while, where we are most vulnerable. And another important statistic is that in our region, about 40% of our deaths in people between 30 and 69 are related to these NCDs. So there's no question that we need to have a sort of a lifestyle change to this. And so we can't be surprised that when we have a pandemic like this one, we tend to see the numbers escalate. And so many people who whose lifestyles, because they have pre-existing conditions, certainly makes them more vulnerable. And that is whether they are in fact vaccinated or unvaccinated. And I was drawn today by a comment about persons and how basically you can have someone admitted and 20, 30 minutes later, they're gone. That struck a chord in me because it certainly does explain what's happened with at least 2 persons I know. And I found it difficult to understand how you could go so quickly. So very helpful. But the question for you really is, when you spoke earlier about, as the deaths escalated, that there had to be a decision about who would be admitted to the ICU and protocols around that. If you could just explain for us a little more on how that worked, you know, in any way that you can. You're overwhelmed with persons coming in, and a decision has to be made. Talk us through how that decision's made and sort of who makes it. I mean, we are really seeking knowledge and learning on this one, because we are facing a situation in our country where it's not quite gotten there yet, we're told, but really where the system's been overwhelmed. How did that work in the UK in the height of the crisis? That's the question.
So in the height, well, I'm hoping that you will not be facing that sort of a scenario in the Caribbean, because, as I said, we have treatment protocols that sort of prevent you from getting to that stage. But in that scenario where you have no treatments available, whatever treatment that you're using is essentially futile in many cases, as in you admit people to ITU, you ventilate them, and you do everything you can to support the organs, and COVID basically takes over, and that is it. Now, in the first part of the pandemic, the idea was to get everybody into an ITU. So Nightingale hospitals were set up across the country with ventilators, just hospital with ventilators that would, you know, take all these patients who required ventilation and ventilate them and get them better. That was the purpose of setting up all these hospitals, these Nightingale hospitals. And what we discovered is that nobody made it to the Nightingale hospital. So patient came in, as I said, and you know, within half a day, 24 hours, they were gone. There was no way you could transport these ill people to the Nightingale hospitals. So that was the first issue. So these Nightingale hospitals just went to waste. There were just lots of equipment, lots of staff, everything, you know, lots of resources just went to waste because nobody made it to the Nightingale hospital. So one of the reasons is too ill to transfer, and the second reason, they were dead within 24 hours. So what was the point of transferring? And the other issue that prevented the transfer is that we discovered that even if we did intubate these people and we did ventilate them, they died anyway. So it didn't make a difference to transfer them to get them ventilated. So protocols had to be developed and scoring systems to decide who would be ventilated and who stood a chance of recovering from this illness. Age was a big factor in determining whether you survived or not. And then to add to that score, we would tally up the type of comorbidities that the patient had. So if they had any chronic respiratory condition, the chances of survival from COVID, even if ventilated or intubated, were practically zero. Practically zero would survive with full ventilation and organ support. That resource would not be useful in this sort of individual. If you had cardiovascular disease, significant renal disease, that would not go in your favor. If you were housebound, you didn't go outdoors, your mobility was severely restricted, you would not survive COVID. So when you have a resource that is limited, so let's say you have a 20-bedded ITU and you have 30 or 40 COVID patients who are seriously ill, you have to use your scoring system to decide who is to go to your ITU. So the government issued a guidance on people to be admitted to the ITU setting. The rest of the patients we knew were going to die. And it didn't matter what you did, they were going to die. So these people were made comfortable on the ward setting. So they were sent to the ward. They were, put on medication to make them comfortable, so that they didn't suffer, and they passed away peacefully. And this was difficult in the setting, in the emergency setting. So I work in a setting where people come in and you do 100% to save them and get them better. That is the purpose of emergency medicine. And suddenly you had to ask staff who are proactive and doing stuff to do nothing. So you had nursing staff, highly skilled, able to intervene and do stuff. And all they had to do was watch people die and keep them comfortable. So one of my staff nurses, she came in the morning, she did her shift, and she, on her particular shift, she had 5 COVID patients dying. And all she could do is watch them die. So at the end of the shift, she said she went to her car, she sat in the car, had a little cry, went home, came back the next day to do it again. And we've seen the stories on TV about staff burning out and staff, unable to cope. And that sort of scenario was going on. So I'm hoping that you are not in that position, because you shouldn't be exactly in that position, because we now have treatments which prevent people from getting to the point where they need intubation. As I said, if you get to the point where you need to be intubated, then it's all dependent on what your comorbidities are. If you have high comorbidity toll, you are not going to survive COVID despite your intubation. So if for some reason you get overwhelmed in your ITU setting, this is the sort of factors that we will look at, and I'll be happy to send you what our protocol was afterwards, and so you can have a look. But I'm hopeful that you will not end up in that situation if you use the treatment protocols that are currently available to try and prevent people getting into the ITU setting. It depends on what, as you said, in your previous statement about non-communicable diseases, as I mentioned before as well, if you have a significant pre-morbid load, your chances of suffering and going through, hardship with this disease is much higher than if you're a healthy individual with no comorbidities at all. So I hope that sort of answers your question, Patrick.
Thank you very much.
Thank you very much, Doctor. And I just want to say that I would ask your advice. What would you say to people? Because I'm sitting here in a house with my brother who's 55 and his wife who has underlying conditions, and the conversation gets so frustrating when you weigh the benefits of vaccination and non-vaccination to them. It gets so frustrating having the conversation over and over and over. And not just with them, but with other people who you think would, you know what, if this can help for the greater good, let's do it. What would you say to people who's just, they're coming up with every excuse, every Nancy story, every excuse to not take that vaccine? Oh, it will make them impotent. It will mess with your sex life. It will, every excuse imaginable. What would you say to these people right now before we come back and wrap up?
The way you have to think about this, I think it's very difficult. If you are impervious to logic, then these arguments and these conversations will go nowhere. So there are some people who will be impervious to all the logical arguments that you can provide. And logic is not going to work there. And there will always be a fraction of the population that is not going to, they don't want to hear the word vaccine, so they're not going to hear about vaccine. The way to look at it really is that vaccinated or unvaccinated, if you catch COVID and you are not, mindful of your fellow citizens, you might get COVID, you might be perfectly well, and you might go and boast to your friends that you got COVID and nothing happened to you. But it's to the people that you may have passed this disease on to. That is the problem. So you may have passed this on to 2, 3, 4 people who may not have been as lucky as you. And you may have come out of this fine, and one of those 3 or 4 or 5 people that you passed it on to may have died. And perhaps that is the argument that you use, that COVID is not just about you. COVID is not just an individual thing. COVID is something that is a collective. Defending yourself against COVID is a collective responsibility. And if you have collective responsibility, you will get yourself vaccinated. It is as simple as that. If you don't care about what happens to other people, then that's on you. That's on you. But there are many people who are undecided in this business about getting vaccinated or not. And our purpose is to provide them with the information that allows them to make up their minds to get themselves vaccinated. We have to provide, as educators, as medical people, as politicians, as leaders, it is our responsibility to provide the correct information to these people so that they can make up their minds to vaccinate themselves. Right now, they are trying to get information, and they're getting information from the only source that they know of. When people say they're doing their research, they're doing their research and they're getting information from the sources that they know, which, i.e., in this day and age, is social media. People don't know about the Lancet and the BMJ and the New England Journal of Medicine and Scientific American and New Scientists. They don't get their information from those sources. But we get the information from those sources, and it is our responsibility to pass that on, whether it be the community leaders, the reverend, the priest, whoever is a community leader. We target those people and we get them to understand the information that we have. We have over 5 billion people in the world vaccinated, fully vaccinated now. That's a lot of data. We have a lot of data on what this vaccine does. It's no doubt at all what the effect of the vaccine is. But we have to find a channel to get this information to the relevant people. But I'm afraid with people who are totally impervious, I said, well, it's not just you we're talking about, it's everybody you're in contact with. Somebody could get killed. But
Thank you very much. Thank you very much, Doc. We appreciate you, all the information you came on here to give to us. So at this time, I would like to invite Mr. Basil Williams to thank you on behalf of TGM, on behalf of Grenada.
Thank you, Janice. Thank you, Doctor. First, I would like to take a moment, if you could have a brief moment of silence for all the ones that we actually lost to COVID. Thank you. And now I would like to recognize the nurses, doctors, and all the frontline workers that is out there every day, going above and beyond, putting themselves at danger. To Dr. Harripaul, we thank you so much. This forum was so informative. It answered a lot of questions from many of us. It gave many of us an opportunity to ask questions and put their minds at ease. And even if just one person gets vaccinated from this forum, I would consider it a success. So from TGM and from the whole of Grenada, we thank you very much. Thank you.
It has been my pleasure to have this chat with you all, and I wish you all the best in your journey and fight against COVID. And I would be happy at some point in the future to chat with you all again. So thank you very much.
Thank you very much, Dr. Harripaul.
Thank you. Thank you very much.
Appreciate it, Doc. Thank you very much. So, ladies and gentlemen, this is TGM shutting down this evening. Once again, thank you very much to Dr. Harripaul, our moderator, Janice, Augustine, thank you very much too. Thank you all for joining us on social media and here on Zoom. We will endeavor to have this up on our social media platforms for you to be able to share with your friends, colleagues, and family during the course of the week ahead, so that we have this as a body of information that you can refer to for facts from an expert on the front lines. On behalf of the Grenada movement, thank you once again. Good evening and good night.